My name is Sarah Clark, and today we are going to be assessing the pulmonary system. This is Tanner. He's going to be my patient for today. So with any of our assessments, we first want to start by just inspecting. We're going to inspect, palpate, percuss, and auscultate. And everything we're going to do anteriorly and then posteriorly. The first thing we're going to do is inspect. The first thing we're inspecting is the anterior-posterior and transverse ratio, meaning that the width of his chest this way should be about twice as big as the width of his chest this way. You can measure it, but you can also just eyeball it. It's normal in adult for it to be a 2-to-1 ratio, which it looks like Tanner's it is. It's about twice as wide this way as it is transversely. In someone that has emphysema or other lung diseases or a barrel chest, you might have a 1-to-1 ratio, or in children it's normal to have a 1-to-1 ratio. The next thing we're inspecting is just the shape and contour of his chest wall. And I'm going to have you lean forward really quickly and just inspect the shape of the scapula, and they are symmetrical and everything looks good that way. Then I'm also just inspecting if he's using any accessory muscles like his intercostal muscles to help breathe, which he's not, or if his nose is flaring or if his lips are pursed, any indications that he's struggling to breathe or having to work harder to get the same amount of breath. And then also just inspect the position he's sitting in. He's sitting upright, he's breathing easily, he doesn't have to lean forward into that tripod position like someone with emphysema would. And then lastly, I'm just looking at the quality of his breathing. He's taking nice deep breaths. You can see his diaphragm moving. He's not breathing too quickly or too shallow. He doesn't look like really he's having any struggle to breathe. Everything looks really normal. A normal respiratory rate is anywhere between 12 and 20. Tanner's breathing about 16 right now, and that all looks good. The second thing we're going to do is palpate. So you start by using the pads of your fingers to just palpate anywhere along the chest. Feel if you feel any lumps or masses or any tenderness when I palpate. Okay, or to see if you feel any subcutaneous air trapped under there. It all feels normal. I'm going to have you lean forward and I'm going to palpate along the back. And it all feels very normal as well. Okay, go ahead and sit back. And then the next thing we're going to do is called tactile fremitus. This is just when you feel for the vibrations when he speaks. So I'm going to have Tanner say 99, and I'm going to use the palmar aspect of my hand and put it in the intercostal spaces. And when he says 99, I should be able to feel the vibrations equally on both sides. So say 99.
99.
And again.
99.
And again.
99.
And
99.
And again.
99.
And one more time.
99.
Okay, and I can feel the vibrations each time he said it, and the most important thing is not if you feel them or not, but the most important thing is that it's the same bilaterally. So I can feel the same amount of vibration on both sides. And I'm going to have you turn around really quickly. We're going to do the same thing on the back. You're going to have to spin a bunch here, sorry. Okay, so say 99 again.
99. 99. 99. 99.
Okay, perfect. All right, you can turn around again. Thank you. It all looks really good. Okay, the next thing we're going to measure is his chest excursion. You do this just by placing your hands on the chest wall with your thumbs near each other in the center, and then have your patient take a great deep inhalation breath. And as they do it, you want to make sure that your hands move equally on both sides. So I'm going to do it first on the front of your chest and then on the back of your chest, okay? So I'm going to have you lift your arms out to the side and take a deep breath for me. Okay, and relax. Perfect. And you can see my hands move the same. And then I'm going to make you turn around again. We're going to do it on the back. I didn't warn you you'd be turning this much this soon.
It's okay.
Okay, so take a deep breath and relax. Perfect. Okay, you can turn around again. Thank you. So both of those, my hands moved symmetrically. And that's a normal finding. The next thing you want to do is percussion for the anterior and posterior axilla. So you percuss by using just your non-dominant hand. You put the finger down and then you tap on it with your dominant hand, and you want to tap quickly and then release your fingers so you're not muffling the sound or anything. So you start up high like this and you just tap, and you should hear you should be able to hear it resonating throughout the chest, as you do this percussion. So I'm going to percuss on both sides bilaterally all the way down, and you just want the sounds to be symmetrical on both sides. And you want to make sure you're doing this on the intercostal spaces. Okay, and all of that sounded very normal and bilaterally the same. So you're going to have you turn around, we're going to do it on the back. So same thing, find the intercostal space here. And one more space. And that all sounds really normal. And while he's seated backwards, we're also going to do what's called diaphragmatic excursion. This is easiest to assess on the back, on the posterior side of the chest wall, because there's not musculature or breast tissue to get in the way. So what I'm going to have Tanner do is just take a really deep breath. You don't have to do it yet, I'll explain it first. He's going to take a deep breath and hold his breath, and while he's holding his breath, I'm going to palpate and listen for where it changes from resonant to dull sound, and where it changes is where the diaphragm has moved to. And so I'm going to mark that spot and have Tanner then exhale and then hold his breath on the exhale, and I'm going to repeat it and see where the diaphragm moves to while he's exhaling. Okay, so first take a really deep breath and hold your breath on an inhale. Okay, good. Okay, so right about here is where it changed. If you can hold your breath, I'm going to do it on the other side as well. Okay, so right about here is where it's changed. If I had a pen and I felt like drawing it on him, I would mark that spot right there. If I press hard enough, it'll probably just leave a mark. Okay, take a couple breaths. Catch your breath, sorry. And then you're gonna blow out and exhale all your air and then hold it right there. Okay. Perfect. And you can start again at the top, or you can just start from the bottom and work your way up for this one. So right about there, and then we'll do this side, make sure it's the same. Okay, and right about there as well. So you can breathe again. So this is about the distance between where his diaphragm was sitting. Anywhere between 3 and 6 centimeters is considered normal. Tanner's is probably actually closer to 6 or 7 if you have someone that's in really good shape. It can be closer to 7 or 8 just because their lungs are very well conditioned, which would make sense in Tanner's case that he has a little bit more powerful lung and diaphragm excursion. Let's see, the last thing we're going to do is auscultate, just all of the breath sounds. And while you're auscultating, you want to make sure that you are listening in all the lobes. There's 2 lobes on the left side of the lung and 3 lobes on the right lung. And you're listening, you want to hear air flow, air movement with each breath. And you want to make sure you're not hearing any crackles or rails or wheezing or rhonchi. Those are all different kinds of lung sounds that would indicate an abnormal finding. Crackling kind of sounds like when you move your hair in front of your ear, it kind of makes that crackling noise. Someone who has asthma you might hear wheezing where you hear like a and you can hear the air having difficulty moving through their lungs. So those are all the things you're assessing for while you listen. I like to always start at the top and move in a ladder position so that I know I'm hearing bilaterally in the same spot on both sides. And then to make sure you hear the right middle lobe really well, the best place to auscultate that is almost under the right arm on this side. So I'm just going to start at the top and use my diaphragm. Okay. And every time you feel my stethoscope, just take a deep breath and then blow it out, okay? You can go laterally to listen to that right middle lobe. And then just for the sake of being symmetrical, we'll listen on this side as well. Okay, and all this breath sounds from the posterior aspect. I can hear breath sounds in all the lobes and they all sound clear and equal. I don't hear any wheezing or crackles. So I'm going to have you turn around one last time and we'll listen on the front. And just same thing, take a great deep breath. Okay, and everything on the anterior aspect as well sounds normal as far as breath sounds. So we've done inspection, palpation, percussion, and auscultation, and that completes our pulmonary assessment.